Today's webinar will be interpreted into Spanish. And so I want to introduce our interpreter, Maria Elisa, and she's going to lead us through how that will work. So everybody, welcome Maria Elisa.
Thank you, Michelle. Good afternoon, everybody. Maria Elisa Fuller here with the Community Language Co-op. Thank you to the hosts of this webinar for their commitment towards language justice, the idea that every individual has the right to express and communicate freely in the language that they feel more comfortable with. So thank you again for that intentionality behind those efforts and for everything that you do as a team to move this work forward. I am going to be providing simultaneous interpretation during this session. Once we activate the channels, you're going to notice that a new icon appears in the bottom of the screen. The icon is a globe and it reads interpretation. If you're joining from a tablet or a smartphone, it's possible that you find the interpretation feature when you locate the three dots in the bottom right corner of the screen. So whether it's the globe icon or the three dots, we're going to ask you to click on it and choose your preferred language. I want to remind you all that English and Spanish are different in length. So Spanish tends to be a little bit longer than English. So please be mindful of your speed while you present to allow the space for interpretation. If you speak too fast, the accuracy of the interpretation can be compromised. And of course, I want to make sure that the rendition of the message is as accurate as possible. Once again, thank you for having me and thank you for helping us push this movement forward with language justice. Buenas tardes con todos, mucho gusto. Mi nombre es María Elisa Fuller y estoy aquí representando al Community Language Co-op. Estoy muy agradecida por la oportunidad de estarlos acompañando esta tarde. Y bueno, quería dar las gracias primeramente a los auspiciantes de esta sesión por su compromiso a favor de la justicia lingüística, la idea de que todas las personas puedan participar ampliamente en el lenguaje con el que se identifican y el lenguaje con el que se sienten más cómodos. Así que felicidades a todo el equipo por la intencionalidad detrás de esos esfuerzos para asegurarse de mover hacia adelante las prácticas de justicia lingüística. Gracias por tenerme aquí. Vamos a activar la interpretación en un minutito. Cuando yo termine de dar de estas instrucciones en español, usted va a notar que un nuevo icono aparece en la barra inferior de la pantalla. El icono es un globo y dice interpretación. Si es que nos acompaña desde un teléfono móvil o tal vez una tablet, es posible que encuentre la opción de interpretación al ubicar los tres puntos en la parte derecha inferior de la pantalla. Los tres puntos estarán acompañados de la palabra more, que se escribe M-O-R-E. Cualquiera de las dos opciones, el círculo con los tres puntos o el icono de globo terráqueo le voy a pedir que dé un clic y active su canal de preferencia. Quiero también recordarles que el español y el inglés son un poco diferentes en longitud. El español tiende a ser un poquito más largo, por lo que les pido que por favor sean bastante conscientes de la velocidad al presentar y al hablar. Si usted habla muy rápido, la precisión de la interpretación podría verse comprometida y obviamente quiero asegurarme de que estoy transmitiendo el mensaje de la forma más precisa como yo pueda. Así que eso es todo lo que yo tengo para ustedes. Que tengan una excelente sesión. I think we can enable the channels now, Jonathan. Thank you again for having me. Have a great session.
Okay, thank you so much, Maria Elisa. We're so glad that all of you can join us this afternoon for a great discussion on community births as a solution to maternity care deserts. We have a great group of folks here who have great expertise and experience in this field, and I'm so glad that you've chosen to spend some time with us this afternoon. We had over 500 people register for the webinar, so we're thrilled that you all have chosen to spend some time with us this afternoon. I'm going to now turn it over to Andrea. Oh, I forgot to introduce myself. I apologize. My name is Michelle Adkins. I'm the director of the Prenatal to 3 Capacity Building Hub, which is a project of Build and funded by the Pritzker Children's Initiative. So that's me. And now I'm going to hand it off to Andrea Palmer, who is with the Pritzker Children's Initiative. Andrea, it's all you.
Thank you, Michelle. And thank you to the Build team for making it possible for us to present this important information today. Today's webinar, I'm going to start off by sort of framing the issue and making sure that we have a sort of common starting point, after which we have 3 rock stars that'll be presenting on community birth options. We will have Indra Lusero, who is the founding executive director of Elephant Circle, and they will talk about the policy landscape. What are the policy implications and issues that should be considered when thinking about community birth? And then we will have Dr. Christina Alonso-Lord. Christina will talk about the work that's happening in Massachusetts. They recently passed the Maternal Health Act, which is allowing for them to integrate community births into their birth ecosystem. And then we will have Dr. Ebony Marcelle. Dr. Marcelle is the director of midwifery at Community of Hope, FQHC in DC, and she will provide the perspective of a community birth center. Following their presentations, we will have Q&A. Next slide. Next slide, community birth ecosystems, a solution to maternity care deserts. The Pritzker Children's Initiative is a division of the J.B. and M.K. Pritzker Family Foundation. We are a national early childhood initiative. Next slide. We have a vision that every child is flourishing and thriving by the time they reach the age of 3, and that their family has access to the resources and services that they want and need in order to help their family thrive. Next slide. We approach the work from a whole child perspective in terms of the whole child within the context of their family and their community. We know that for kids to thrive, it's going to take more than early childhood education. So we also look at being born healthy. We look at housing. We look at economic security. We look at food security as being key issues that we need to address in terms of systemically in order for families with infants and toddlers to flourish and thrive, beginning prenatally. Next slide. And so the issue of why do we need community births options? Next slide. I just want to provide a little preliminary data, and that is in 2022, there were approximately 3.6 million births, of which 10.38% were premature, which means that those were kids that were born at 37 weeks gestation or earlier. 41% of those births were covered by Medicaid. If we look at the moms and determine their access to prenatal care, 77% access prenatal care during the first trimester, 16% second trimester, 4% third trimester, and 2% had no prenatal care. And in 2022, 20,577 babies died before their first birthday, which is equivalent to 5.61 births per 1,000 live births. The U.S. has the highest rate of maternal mortality among the 14 highest income countries in the world. And when you look at racial disparities, the rates are even higher. The United States and Canada have the lowest number of midwives and OBGYNs at 16 and 13 providers per 1,000 live births, respectively. Next slide. And so why are there maternity care deserts? In 2018, the Association of American Medical Colleges forecasted that this was going to be an issue. They released a report called Labor Pains, the OBGYN shortage, and they indicated that there was a shortage of OBGYNs that was endangering women's lives and causing them to have to travel long distances to receive care. They predicted that there would be 22,000 fewer physicians than needed by 2050, and that the shortage hits rural women the hardest, with over half living in more than 30 minutes away from a hospital with perinatal services. And let me also say, when I say women, I mean that in the broadest term possible. And so thinking about, I know that all women do not necessarily refer to themselves as women. So I just want to make sure that I'm being clear that I'm trying to be as respectful as possible when I use that term. In 2024, the March of Dimes released a report, Nowhere to Go, Maternity Care Deserts Across the United States. And they indicated that 1 in 10 birthing people, or approximately 2.5 million women of reproductive age, live in a maternity care desert, which is a county without a single birthing facility or obstetrician. And that between 2020 and 2022, over 10,000 babies were born prematurely, living in areas designated as a maternity care desert. They indicated that mothers living in a maternity care desert are less likely to receive prenatal care and more likely to deliver their babies prematurely, and that chronic conditions related to poor health outcomes like prepregnancy obesity, hypertension, and diabetes have increased significantly since 2015 and are most common among women living in maternity care deserts. And when you think about it, the idea of not only are they maternity care deserts, but they're also, with the hospital closures and the reduction in physicians, they are not getting preventive care, which is why they're probably more sick than mothers that live in areas where preventive health care is more regularly available. Next slide. And so their recommendations, they recommended the midwifery model of care as a crucial strategy to improving access to maternity care. And it's really about thinking about the options that are available to moms in terms of, so if hospitals are closing in rural areas and in other spaces, and if there's a shortage of physicians, people are still having babies. And so how are we going to be able to assure that they have options for safe delivery of their children? And so midwifery is definitely a strategy for doing that, the midwifery model of care, which not only includes nurse midwives, the certified professional midwives, as well as birth centers, which are, and home births. Some women are choosing to deliver at home. And in order for us to really have a high quality midwifery model of care, there are certain policies that need to be considered, including enabling midwives to practice to the full extent of their education, eliminating requirements for midwives to be co-located with physicians, allowing telehealth technologies, ensuring that equitable inclusion and reimbursement systems were the March of Dimes recommendations. One recommendation that they did not include in their report was around certified professional midwives. At this point, nurse midwives are licensed in all 50 states. Each state licenses makes an independent decision about licensing certified professional midwives, which are the midwives that provide care in the community. Next slide. And so when we think about the birth ecosystem, as I mentioned, you have the healthcare sector, which includes the hospitals and the physicians, but thinking about including or expanding that to include a community birth ecosystem. And what would that include? That includes your healthcare providers, which again are your nurses, because we're not talking about creating an ecosystem that is outside of the healthcare sector, but aligned with and part of. So you have community birth and hospital birth. And so in the birth ecosystem includes the physicians and nurses, it includes midwives, social and non-clinical support, which would be your doulas, community health workers, and home visitors, your social workers, behavioral health specialists, and lactation specialists, case managers, and care navigations. And then it also includes the wider range of locations, which are your hospitals, birth centers, and home. And that this ecosystem, this birth ecosystem, is undergirded by training and licensure, and that and quality assurance, as well as adequate public and private financing through Medicaid and private insurance. Next slide. And so when we think about the birth ecosystem, particularly those of us in an early childhood space, you might wonder, well, why should that matter to us? And why is that our issue? It's our issue because if we think about wanting kids to flourish and thrive by age 3, the first benchmark for that to happen is for them to be born as healthy as possible. And so that means we need to be thinking about where is care being provided during the prenatal period and where are moms accessing delivery services. And if we understand that right now, because of the gaps in care, that babies are being born prematurely before 37 weeks gestation in maternity care deserts. And what that means is that they're more likely to have developmental delays, health issues, behavioral issues, and attention problems, as well as lower third-grade reading scores. The leading cause of infant mortality, including sudden infant death syndrome, is our preterm birth and low birth weight and birth defects. And so having maternity care deserts are contributing factors to all of that. And then if we think about the birth ecosystem and align that with the early childhood ecosystem, we really are talking about very similar sectors: infant and early childhood mental health and early relational health, aligned with maternal mental health. If we think about home visiting and community health workers and doulas, they're serving moms and babies. If we think about coordinated intake and care coordination, we are supporting moms in receiving care for their babies, if we think a little bit further upstream, we can ensure that they're receiving care during the prenatal period. And then, spoiler alert, we're talking about the same moms and babies. And so why not think about it more comprehensively as one ecosystem of birth? And so I wanted to, before I hand it off to Indra to talk about policy, I wanted to talk about some of the things that are happening nationally with respect to maternity care deserts. And so, Jonathan, if you could put those links in the chat, I would appreciate it. And so the March of Dimes has, as I mentioned, their report, Nowhere to Give Birth. And the link that Jonathan is putting into the chat will give you access to not only their recent report, but additional reports that they have from previous years. And there's also my understanding that they are developing a new edition, which will be released in 2026. There's a link to the National Governors Association, where there's a commentary on strategic opportunities for governors. The National Academy for State Health Policy has a policy academy for 8 states that are working to address issues related to maternity care deserts. And talking with them, I learned that when they announced their policy academy, which again was open to 8 states, they had over 20 states express an interest in working on this issue. And so the issues around maternity care deserts are widely recognized across states. And then there's the Rural Health Transformation Program, which is injecting $50 billion into rural healthcare over the next 5 years. And so the link that Jonathan is putting in the chat is a link to the Rural Health Transformation Program tracker. And that's going to give you access to information on what each state is doing in terms of their application for this funding. Many of the states are dealing with issues related to maternity care deserts. Next slide. And so I will turn it over to Indra Lusero, who will talk about policy.
Thank you, Andrea. So good to be here with you all today. Such a pleasure to be able to talk about this important work. I'm Indra Lusero. I'm the founder and director at Elephant Circle, which is a birth justice organization. And we're called Elephant Circle, inspired by how elephants circle around to protect their herd. In particular, when there's an elephant giving birth in the herd, the elephants will circle around that particular elephant and stay for the duration of labor, really connected to the process that elephant is having, but then also forming a circle of protection and defense. And that's the same kind of circle that human beings need. And that's what inspires our work at Elephant Circle. Just to give you a little context about myself and why community birth is important to me in particular, I am the oldest of 4 kids, and I got to be at my 2 youngest siblings' births at home when I was a kid. And I think that really informed my worldview. And then my own process with my kids was informative, and my youngest kid was born at home in the care of midwives. From that point, I was so fascinated about our whole structure and how this optimal care that I had personally experienced was so remote from so many people. The vast majority of people in the United States do not get to access this optimal form of care. And I was fascinated about why that was. And so I went to law school in order to better understand this whole infrastructure. And that's what brings me here today. Okay, next slide. So whenever I'm talking about policy, I think it's very important to really start with the people. Policy can feel kind of alienating, far away, but really policy is a human activity, and we should really remember that policy making is a practice of listening. So pictured here is, folks, a number of these folks are wearing Elephant Circle t-shirts. This is a community event, and it's just a little example of the many ways that we engage with and listen to community. Elephant Circle created a comprehensive birth equity bill package that was really designed from listening to our community over many years. We've now replicated that work in Michigan through the Michigan Momnibus. And we've for many years have also worked very closely, actually with many of you. I see many folks I've spoken with and worked with across the country. And you'll hear a little more about Massachusetts next. And they're another state that we've worked with for many years. I think it's important in particular to foreground the value of listening to people, listening to families, because the infrastructure that we have today for maternal health was not designed by or for families. It really was designed for a medical system that was really just in development itself while this infrastructure was being built. And so we have now, in the information that Andrea shared about the gaps and the deserts, we have information about the extent of that infrastructure and where it doesn't work. And what we need then to fill in that gap is to hear from people. Okay, next slide. From all of our work with people, and pictured here is our celebratory bill signing from the Colorado Birth Equity Bills, is that any policy that strives to address these issues should really take into account these 4 key ingredients: human rights, midwifery, data and systems, and quality improvement and innovation. These are the 4 things that we've found are critical in order to begin to transform the system to make it more effective for families. And I think it's worth noting, sometimes human rights is seen as not a healthcare issue, but in fact, in our work, we understand that human rights are a health outcome. So human rights in and of themselves advance health, and so should definitely be considered as part of a health outcome. Okay, next slide. So this crisis that we have, I have colleagues who refer to it as a manufactured maternal health crisis. And that's because it results from policy choices, structural choices that are systematically disadvantaging pregnant people and midwives. Pictured here in this graphic of smiley faces, we have a portion of them grayed out and a portion of them are colorful. This graphic represents the proportion of women who are disadvantaged in existing health interventions. So this comes from a report called Closing the Women's Health Gap, a $1 trillion opportunity to improve lives and economies. This came out from the World Economic Forum in 2024. And I think it's a helpful image that kind of grounds us in these issues to just remember that across the healthcare system, this is a system that is disadvantaging women. Actually, it's the grayed out number. So 60% of the time, any health intervention is disadvantaging women due to lower efficacy or lack of access. So when we translate this data into the perinatal health context, we know that then essentially all of the perinatal health context is disadvantaging women who it's mainly supposed to serve. So that's troubling. And let me tell you more about how this, what we come to understand is redlining, is working. Next slide. So redlining impacts maternal health. Of course, there is the historical home loan redlining from decades ago and that's where the term redlining comes from. We're applying it here to illustrate the ways that policy choices essentially are devaluing some and increasing the value for others. That's what policies do. On the one hand, we know that those home loan redlining policies are having present day maternal health outcomes that are impacting the families that we care about. So that's just one example of how redlining impacts this field today. But there are other forms of redlining. around pregnancy and pregnancy-related policies. For example, I highly recommend this article from the New York Times, came out in November last year. It illustrates that the use of continuous electronic fetal monitoring is deemed by many to be, quote, the worst test in medicine. It increases risks for pregnancies. But because businesses reap financial upsides, this worst test in medicine is pervasive. The vast majority of people who give birth in the US experience this, interface with this worst test in medicine. So that's just another example of the kinds of choices that the system is making that disadvantages people. Okay, next slide. This is a picture of our status quo infrastructure. And I think it can be helpful for people to see when we're talking about policies related to the perinatal period, what are all the kinds of policies that we're talking about and where do they live? So in this map, we know that many of those policies live at the state law level. Many of them also then live at the federal law level. But I think it's important to note that there are also a number of system pressures which can result in policies that are not necessarily big P state or federal law policies, but are nonetheless policies that impact people. And then finally, there's a whole realm of standard setting. And that standard setting is sometimes woven into state or federal law or both. But the standard setting itself is something that is happening mainly in private organizations. Some of them mentioned here, organizations that do accreditation, like the Joint Commission or the Commission for the Accreditation of Birth Centers, certainly also schools, and then credentialing organizations. So with these four prongs, we broadly cover the kinds of policies that exist. I'm going to dig into just a few of these, but keep in mind as we dig in a little bit that there is an even broader context, and we could spend, of course, many webinars digging into all of this. Okay, next slide. Okay, so one of the issues, and Andrea referred to this, is licensing. Licensing is a state law issue. It's a very common form of healthcare regulation. Licensing exists for both facilities and providers. And often licensing is then tied to payments. So via reimbursement from private or public payers. So thinking again about where licensing fits in that prior slide, it is part of what creates an environment that essentially supports things like midwifery, supports things like human rights, or creates a more restrictive environment. Our work at Elephant Circle is really about focusing on what do pregnant people and their families need in terms of licensing. And sometimes what we've found then is that licensing or not licensing is a critical choice. And sometimes not licensing should be on the table as much as licensing, depending on what the issues are. So for example, I would recommend not licensing doulas as community-based health providers, because that will limit the workforce, that will restrict who's able to provide this critical community-based form of support and care. So the choice to not license is one that really focuses on the needs of families and pregnant people and how to get them what they need most efficiently. This picture also, it comes from Birth Detroit, our colleagues there, and this is at their ribbon cutting for their birth center. I'll try to remember to highlight what some of the pictures are about. Okay, next slide. Another piece of that puzzle, which was again illustrated on that map in that upper quadrant, is payment systems and malpractice. So both the payment part and the malpractice part, those aren't healthcare themselves, but they definitely shape the form of healthcare and really the outcomes. So, for example, the United States, this is data, well established, overuses subpar interventions, but then underuses really high value, high quality interventions. And this is at least in part due to how the payment systems incentivize those subpar things, like that continuous electronic fetal monitor, the worst test in medicine, for example. The other way that we see payment systems and malpractice impacting outcomes is, for example, with malpractice policies and malpractice laws. So states with provider-friendly malpractice laws, so laws that are less punitive towards the provider, actually are correlated with a higher use of risky but organizationally expedient practices, like early induction, for example. And I refer to some sources here that I definitely recommend if you want to dig deeper into these. But I illustrate these just to give you a sense of, again, that map and some of the details in that map. So these systems can be reached by policies, but it is complicated. And often when people dive into this field and they think, how are we going to address maternal health crisis, maternal health deserts, they don't start by thinking about the payment systems or the malpractice policies, but that's a really critical place to look. Often, those kinds of conversations in particular about payment, about malpractice, those are left to the insiders. But this is another place where I think it's extremely important to involve community. So this is actually a picture here of a Zoom stakeholder meeting we held that included a combination of people from malpractice insurance companies, health systems, managers and risk managers, but also community people. Next slide. This is the last deep dive into the system map. But I think it's really critical to this field. And that's the idea of risk. Anytime that we're addressing these issues, risk is, if it isn't being directly spoken, it's one of the ideas that's deeply informing the conversation. But the thing about risk, and this is why in the image, I've sort of circled the system pressures and standard setting components of the map, because risk really comes up in those places in particular, often unseen. But the tricky thing about risk is that there really isn't a shared definition. There is no such thing as a singular risk. Risk is cultural, risk is personal, risk is contextual. There are definitions of risk built into this all over the place. But those definitions don't necessarily align with how families would define risk. And we know this again from our extensive listening to families across the country. And so a lot of times people feel like this infrastructure isn't adequately addressing the kinds of risks that families think it should. At the end of the day, part of what's extremely challenging about this work is that fundamentally the perinatal period is about ambiguity and uncertainty. And ambiguity and uncertainty are going to feel risky to a lot of people. The fact that it stretches across time and there are so many different things that can happen that are unknown at the beginning of the time and that can stretch across time, that just ups the discomfort for many. I think it's really useful to know about this concept called the need for closure. And that's basically how people respond to ambiguity and uncertainty. And some people are going to need, regardless of the fact that things may be uncertain, they're going to just need to nail it down, need to come up with something certain in the face of that. And that's this need for closure. We see this need for closure happening across the policy landscape. And so I really wanted to highlight it here for you all to keep that in mind. Okay, next slide. As much as I started with listening to people, I also want to end there. One of the things that Elephant Circle did in 2023 was to host 2 people's tribunals. A people's tribunal is basically a forum where people get together to acknowledge, to address, to recognize harms that are not well recognized in other formal places. And so we can do this as people amongst ourselves. In order to address obstetric racism, obstetric violence, these ongoing harms that are not well addressed in this system, we held these tribunals. And the speakers at the tribunals contributed to this report, which came out at the end of 2024. From that report, I just want to highlight these 4 things that these families are saying that we need. We really need to listen to community voices. We really need to amplify community power. And then from that, we need to demand systems change. So again, we need to see that map change. And we need to catalyze creative solutions. And I am thrilled to pass the mic over to my colleague, Christina Alonso. And then later you'll hear from Ebony Marcelle, who I think are great examples of this catalyzing creative solutions and really all 4 of these things. So I'll pass it over to you, Chris.
Thank you so much, Indra. And thank you, everybody, for coming this afternoon. Indra really teed up so much of the context that will help you understand what we're trying to do in Massachusetts. And hopefully I'll be able to walk you through what's been happening in Massachusetts in the last 2 years specifically. But also to Indra's point, we got to where we were today in Massachusetts because of the constant, persistent of advocates who themselves had either community births or hadn't been able to have community births because of the system that we have, and advocated over the course of a decade to really implement change in the state, which is kind of what we're going to zone into now. So next slide, please. So I have the honor of working as the Division Director for Pregnancy, Infancy, and Early Childhood in the Department of Public Health in the state of Massachusetts. And I will say that I come from this in a background of community work and birth centers. So I was a home birth midwife for almost 20 years and ran birth centers. So I'm coming at this, I do want to start with the fact that it is rare to have people that were community birth advocates or professionals or even stakeholders working at the government level. And something that Indra did not mention is that a study that Elephant Circle did last year, 2 years ago, actually, a lot of work related to birth justice. One of the conclusions that came out of that analysis was the lack of folks that are, the lack of, I'd say, participation of doulas, community midwives, and people that have had community births at the government, academic, and the large NGO level. So these large non-governmental organizations or policy think tanks that are really moving the needle on community birth, we often see this chasm of, it's typically PhDs and people with a lot of experience in policy. And so one of the things that I think is important to recognize in Massachusetts in changing the system is one of the first things they started doing is hiring home birth midwives and doulas into the Department of Public Health and into our Medicaid agency to start actually leading this change. So I'm just going to park that right there as one of the first things that needs to be. I'm not going to say what we should do, but one of the things that Massachusetts did that I think is critical to leading the change. Next slide, please. So we're going to talk a little bit about Massachusetts, a tiny state that thinks it has everything worked out and we're really great. But it turns out that when it comes to maternal health, we're really struggling. And we're going to look into a little bit of the data of what it looks like to give birth in Massachusetts. Then we're going to look at the community birth integration strategy that came as the result of this huge maternal health omnibus that was passed in August of 2024. And then as we look at this map, I'm going to update you on how are we doing with implementation. So next slide, please. So many of you might or might not know that Massachusetts is the home of the American Medical Association, and this has driven policy. Just as Indra said, that policy is made by the people. The people that have been driving birth policy in Massachusetts have really driven a lot of medical innovation. We have great hospitals here, a lot of electronic fetal monitors, to the comments in the chat. And so we really have a system where in Boston, you have your choices are between 5 academic medical centers. Those are your choices. Choosing a birth center is actually not permissible, that we have no birth center in Massachusetts. The one that we had, I mean, in the Boston area, the one that we had closed down during the pandemic. And then for the rest of the state, we see that every year we lose a maternity unit. So right now we have 38 maternity hospitals. We lost another one maternity unit went on suspension last year. So at the rate we're going, if we continue this trend, in 38 years, we will have no more maternity units left in the state. So what that means is that if you live in Boston, your risk of a highly medicalized birth is really high. We have a higher than national average cesarean rate. Our cesarean rate is almost at 35% for the state. So a lot of interventions, a lot of hospital work. Most people are giving birth in academic medical centers with a lot of interventions. But then for the rest of the state, if you drive 2 hours or 3 hours outside of Boston, your choices are few and far between. And we're seeing this, in all states, where definitely around the capital, or so there's sort of one city that has a lot of academic medical centers, and the rest of the folks are kind of like, they just have to drive somewhere. And what we're seeing too is this is also translating in tremendous inequities. And so when we look at both our maternal mortality and our maternal morbidity, morbidity being people who don't die of childbirth but are injured by it, so might end up in the intensive care unit, might end up with organ failure. These folks, what we're seeing is that our disparities among non-Hispanic Black birthing people are outrageous. It is absolutely unacceptable when you look at these rates, looking at the outcomes for non-Hispanic white people compared to non-Hispanic Black people. And we're seeing, tragically as well, the Hispanic outcomes starting to get worse and worse. Recently looking at we recently published our maternal morbidity rates for the last 2 years. And again, they continue to increase, meaning that birth is becoming more dangerous for Hispanic and non-Hispanic Black folks in the state. And yet we are inducing more and more people, and we are doing more and more cesareans. So all of these interventions are not translating into better births, healthier people, and stronger parents to take care of stronger children. So next slide, please. So what happened in August 2024 is that our governor signed a bill into law that is incredibly broad. It includes the legalization, or the regulation, I'm going to call it the regulation, of certified professional midwives, which are non-nurse midwives. These are midwives that are trained through a direct entry program. And until now, they were not regulated, functionally meaning that they couldn't help people have babies in Massachusetts, meaning that community birth options were very slim. It called for redoing the birth center regulations. Our birth center regulations were very centered around having to have an agreement with the hospital, having to have privileges in hospitals, really kind of focusing the birth center as a place where it was almost an extension of a hospital, and not honoring birth centers as freestanding facilities that operate under a specific model of care. So we've redone the birth center regulations in an attempt to make it easier to open more birth centers faster. It also calls for reimbursement of doulas through our Medicaid program. It also calls for screening and treatment for postpartum depression of all birthing and pregnant families in Massachusetts, and a whole slew of other laws and regulations that we're putting into effect. I'd say that we often call it the midwifery bill. We tend to call it the maternal health bill because it really centers on it is sort of the culmination of 3 large reports that the state did looking into the state of maternal health and trying to figure out how to fix these disparate outcomes. Next slide, please. So what happened was I actually started working at the Department of Public Health in April of 2024. And in August, I was happy enough to be at the State House with many of my colleagues when this bill was signed into law. And oftentimes in advocacy, we get really excited when a law passes and we're like, great, the policy win, we're done. But actually, when it comes to state agencies and government, is the next chapter is, okay, so how do we actually turn these words on a piece of paper into something that makes it so that when you become pregnant in Massachusetts, you can say, well, where do I want to have my baby? In my house, in a birth center, at a hospital? What fits for me? What's the best choice for my family, the kind of birth that I want, so that every single person that gets pregnant in Massachusetts can choose that and can also choose their course of care. Maybe they want prenatal care in a birth center, but they feel more comfortable giving birth in a hospital because they want an epidural. But so that everybody can, your choice of where you give birth is not what academic medical center or how far am I going to drive, but is really looking at the choices that we have. So the thinking that we did in my department was, how are we actually going to operationalize this? And instead of looking at, okay, well, certified professional midwives will have a license and doulas will be certified and reimbursed, and good luck to everybody. I hope that birthing people find out this information and good luck, bye. We actually decided to design what we call the community birth integration strategy. And what it does is it holds the state responsible for actually changing the birth ecosystem so that the choices that Indra mentioned reflect a human rights approach to accessing the midwifery model of care, where data, systems, and quality improvement actually drive the work, instead of us reacting to the fact that now, oh dear, people are choosing home birth, and that might make some people uncomfortable. So next slide, please. This map started as a doodle on a napkin, as all great ideas start, and it's actually now turned into a statewide integrated strategy that hopefully will be funded this year if the legislature approves that. Our governor did just include funding for this in her budget, so we're hoping that the legislature will continue that path and we'll be able to really implement this work deeply in the next year. But if you look at it, it really takes, it really kind of considers that to build an ecosystem, you have to address all of the pillars that are part of that ecosystem. And so on what I can see is the left side, the blue side, we're looking at what the International Confederation of Midwives identified as the key pillars for integrating midwifery into a healthcare system. So you need strong associations. These are the folks that are speaking for the rights and the perspective of the folks that they represent, be that doulas, midwives, birth centers, and other folks. Then you need education. So you cannot have the right to access a home birth if we don't have a certified professional midwifery educational system. So one of the things that we did quickly was start talking to community colleges in Massachusetts. Community colleges are free for Massachusetts residents. And so we're in the process right now of working to open a CPM accredited program so that Massachusetts residents can become midwives and then can serve the people in Massachusetts. So we see it as coming arm in arm. If you want a workforce, you have to build it. There is only one other state program in the country, and that's in Wisconsin for CPMs. The other piece is regulation, and that's our wheelhouse. If there's one thing that departments of public health do well, it's write rules. And so what we did was immediately we built up this 9-person midwifery board. It has 5 certified professional midwives on it, 1 nurse midwife, 1 obstetrician, 1 maternal fetal specialist, and 1 public member. And so the board is guiding the regulations, making sure that they're grounded on the reality of CPM practice and philosophy. We also worked with doulas to create a doula certification that will launch on March 16th. And I do want to highlight, to Indra's point, that our doula certification process is voluntary. It is absolutely not mandatory. And our Medicaid reimbursement is not going to be tied to doula certification. So it's going to be something that if doulas want it, they can get it, but it's not going to be mandatory. Again, We're also working on lactation consultant regulation, and this is to enable reimbursement. And our birth center regulations were already rewritten and published last year in February. I want to say too, as part of this regulation piece, is that we are also investing in birth centers. So this month, we are contracting with 5 birth centers, 4 birth centers and 1 nursing school, to distribute another $1 million. This is the third $1 million that the legislature is pouring into the community to be able to enable birth centers to open. So not only did we rewrite the regulations, we're also trying to support financially because we know how difficult it is to actually get a birth center off the ground. And the third piece I'll say about regulations, that we're in the process too of working with a financial consultant to address the reimbursement challenges. And I'm sure Ebony can talk about this, but birth centers are really challenged by the reimbursement rates. And so we really want to be able to address this because we don't just want to open birth centers. We want to make sure that they thrive and that they're part of the system. I'm going to skip over to transfer of care because that's a piece that we've already also worked really hard on. And the big part that makes people really nervous is what happens when something goes wrong. And it's the first question you get as a home birth midwife. What if something goes wrong? Oh, we'll take you to the hospital. It sounds a lot easier than it actually is. And so one of the places where we see both the most harm and the most trauma being done, not just to the birthing people, but also to midwives, the receiving obstetric or neonatal team, and also the folks that are involved in the transfer, the EMS or the person who's driving the car. It can be incredibly traumatic when the birthing team doesn't know what's happening, when we could have transferred earlier, but we didn't, et cetera. There's thousands of stories about how this could be done better than it is. And so when one of the first things that we started doing was implementing transfer of care drills. And so to date, we've worked with 10 hospitals. And what we do is we bring together the community midwives in the area. We bring together the EMS services in the area, and we bring together the hospital, the OB teams in the area. And so we pretend that somebody's in labor, there's a complication, there's a whole drill kit to do this. And so what we're doing is practicing these drills so that we can figure out what's working well and what's not working so well. This piece of the kinetic experience of doing these drills is such a game changer on the upper piece of public information and the middle piece of obstetric providers. How are we going to move the needle on culture change, on understanding that when we think about birth, we're not just thinking about what hospital do I want to go to, but what really are my choices? And how are those choices supported by a system that is going to support me no matter what my choice is and no matter what happens during that choice? Maybe the baby, I'm just not advancing in my labor. Maybe there's an emergency, but the system is there to serve me and to take care of me and to make sure that I'm not traumatized by that event, and that we're all working to lower these abysmal maternal morbidity and mortality rates that we have. And so finally, I'll say that this, of course, because we're the state, we're able to collect piles and piles of data. We're able to look deeply into what's working and what's not working. And so hopefully we'll be able to also bring on a specific database to community birth so that we can track how births are going in the community, how transfers are going, and how integration is going. And so really when I think about this integrated strategy, what I want for my daughter, who's 4 years old right now, is that when she's at the age where she decides that she wants to be a parent, that she can really look and say, this is the kind of birth I have, and no matter what happens in it, I will be supported, I will be strong, and the system will be there to serve me. So I'm going to close on that to pass it over to the person who's been doing this work for so long, who's Ebony, my colleague who runs the birth center in DC. So thanks, Ebony.
Hello, everybody. So happy to be here. And man, they are a hard act to follow, but I'm going to do my best. My name is Dr. Ebony Marcelle. I'm the Director of Midwifery at Community of Hope, which is a federally qualified health center in DC and one of the remaining 5 federally qualified health centers that also have a birth center. Next slide. Next slide. So just to give a quick overview about Community of Hope, they actually started over 40 years ago in housing. And then as the years progressed, started added a medical arm. And since then, not only have a medical arm, also have a dental arm and also an emotional wellness arm. And I'm here to argue that yes, you should definitely think about supporting the further development of more federally qualified health centers that also have birth centers. I want to share with you our model, our unique model, and also talk about our MCH program and some of the challenges, right? Because nothing is easy, and some of the things that we've kind of learned along the way. Next slide. So just to also give you some kind of like background demographics, DC is built like a diamond. And the bottom half of the diamond is where we see the most of disparities. If you look at these dots and you look at where the river is, you commonly will hear east of the river. This part of the city for years has not had a hospital. We just had a hospital open last year, but still kind of going through its transitional growing pains. But all of the hospitals were at the top part of the diamond, which meant the most under-resourced families needed to travel to the top part, which sometimes on public transportation could take up to 2 hours to get medical care. And until that hospital opened, we were the only place to give birth below at the bottom part of that diamond, the birthing center. Next slide. So we have a really, really great story. The top picture is showing the original birth center that was the brainchild of Ruth Lubick, who won the MacArthur Grant. It was an old grocery store, and the concept included a birthing center, a nurse-led project, and an early childhood development center. And it was about 7,000 square feet. But of course, anybody that's familiar with bigger cities, gentrification, changes, we had to move. We had to move. And the thing that I am very proud about is that we asked, well, primarily leadership, asked the community, was it important for us to stay nearby where this current location was? And they said yes. And so it took a very long time for us to find another property, but we moved to a much larger, grander location, lots and lots of hard work, about 7 minutes away from the old location. And we tripled in size. Next slide. These are a couple pictures of our birth rooms. I'm sitting in one right now. Next slide. And this is our patient demographics. We're predominantly Black. At the two locations that the midwives see patients, predominantly Medicaid. We have a little bit of private insurance in the grand scheme of things. And we are really trying to make sure that we have cultural congruency in our care providers. And I'll talk about that a little bit more. The next slide. So why would you want to do this, right? First of all, anytime I have the opportunity to talk, I like to let people know, as much as I love birth centers don't make money. Birth does not make money. And I think we just need to keep kind of practicing that to say that, because that's part of the reason why there's been such a demise in birth centers in this country. Two of the largest ones, two of the oldest ones have recently closed in the last couple of months. And so what are some of the benefits that you get being a birth center that's inside of an FQHC? Resources, right? Lots and lots of resources being a federally qualified health center. We have the opportunity to have a federal Tort Claims Act for malpractice, which is another big reason why it's hard for people to sustain centers, sustain practice for the high rising costs of malpractice. We have enhanced Medicaid reimbursement for the families that we are taking care of, and just the integration opportunities, right? So anybody that's getting care with us for perinatal care has the opportunity to have emotional wellness. They can go to dental. We have a pharmacy. Our pharmacy delivers to our families. And just being able to continue to bring more and more services, having us all together in one space and not having to have families travel all different places for all the things. Next slide. So we have great outcomes, right? These outcomes are from a couple of years ago. This was made for us by Optum, but we're able to show that we have lower preterm birth rates, low birth rates, and we are commonly caring for a community that is usually higher than the national average. So what we're doing is absolutely, it's working. Next slide. Just also showing some comparison data with, DC Medicaid specifically, and also looking at specifically Black and Hispanic families. And I'm going to talk a little bit more about some of the ways. So we like your next slide. This is what I was waiting for, my beautiful, we like to call it our flower. This is a beautiful graphic of what kind of care we're able to provide. So we have prenatal care with our midwives, but also our family providers are providing the midwifery model of care. We do centering pregnancy. For anybody that's unfamiliar with centering pregnancy, it's group prenatal care that was developed by a midwife in the 80s, has shown to decrease low birth weight, decrease preterm birth, increase maternal satisfaction, increase breastfeeding success rates. We have perinatal care coordinators that engage with families from the onset of pregnancy till 6 months after. All of our midwives have privileges at our hospital, about 7 minutes away. We provide transportation for our families. This has been a huge game changer. And not just for like appointments, it's also for specialty. And my favorite, it's for rides in the middle of the night for triage when she thought she was in labor, but she's not really in labor. So terrible the times that we have folks in the middle of the night stuck. We have on-site sonography. So the midwives are doing dating scans, also positional. We also do biophysical profiles, AFIs. And again, this is just us learning how to continue to build more and more into what we're able to offer to our families inside of our house. Instead of giving them referrals, that sometimes, we're not able to get people appointments outside of us for, 3 and 4 weeks. We have maternal fetal medicine 6 times a month at our Conway location, which has also been really, really incredible. And at this point, and still at this point, for at least for the last 7 years, they're the only MFM east of the river at that bottom part of the diamond. We have pediatric care. A lot of people don't know that midwives provide newborn care. So most of our families that birth with us bring their babies to us for newborn care, and then we transition them to our family providers. We have early childhood home visiting, parents as teachers, nurse something pathway. I'm forgetting the name. I'm sorry, nurse visiting. Forgive me. We use both of those models for early childhood home visiting. And then this is my baby. This is my favorite petal. We provide home-based postpartum care. This was based off of a grant we got to provide. There it is. Thank you, Andrea. Nurse Family Partnership. But we got a grant from the Hillman Foundation to reimagine what postpartum care could look like and what it would look like to engage with families for a year. And so we did a series of listening sessions, surveys, and co-designed this program that the first 12 weeks are home-based, and then we continue to engage with families with peer-led support groups, parent cafe, infant massage, baby wearing classes, and just try as much as we can to transition them over to primary care if needed for other complications, but just making sure we stay engaged with families. Oh, I'm sorry. We also do centering parenting, That's also how we're staying with our families, but just trying to do everything possible to stay engaged with families that first year, right? So we know that the numbers show how many families are impacted, how our maternal mortality and morbidity is impacted during the postpartum period. And I feel like it's one of the most neglected times in our maternity care system. So we have been growing as much as we can, trying to change the way that we are caring for families during the postpartum period. We have breastfeeding support, education, we have making milk classes, we have an IBCLC that visits our families. We are a WIC site. Yes, we are a WIC site. So no longer having to give somebody a referral and say, go across town to possibly catch an appointment. We have WIC on site, and we give out baby items. And you know what, I will also add not only baby items, such as like diapers, breastfeeding supplies, we give out pregnancy supplies. So we give out, balls, belly bands. For a while, we had a beautiful grant that gave us nursing bras. You would be surprised how many people really, really appreciated the nursing bras. And if you look in the center, it just shows you how this is all hugged with our primary care. We have a very strong relationship with the rest of our providers, and the continuity is insane. So, we have families that maybe are with us for their family building and then navigate right over to our family providers, come back to us again when they're pregnant again, and then go back to the family providers for primary care. Patients start off with us, maybe this is their first time experiencing Community of Hope, and then now the partner comes here for care, and now her mom comes here for care. Really, really trying to grow multi-generational continuity with the families of this community. And then integrated emotional wellness, what a journey it has been to really, really provide strong emotional support. And so I commonly will give the example, for years, if somebody was having some struggles, I would have to try to make a phone call, give a referral, maybe they can get an appointment and 3 to 4 weeks. And now I can say, Esperanza, can you come to room 5? Mrs. So-and-so is having a hard day. Being able to have immediate emotional wellness is key. And that has also extended now to not only emotional wellness counselors, we have somebody specifically for addictions. We also have a psych NP for folks that need medicinal management, and we have a per diem psychiatrist as well for folks with maybe a higher acuity of medicinal management. And then at the very top, you can see the little B. We got a large HRSA grant to really start working on some interventions towards pregnant people experiencing homelessness. So like I said, Community of Hope is foundationally grounded in housing support, but the way that DC works, you love systems, right? Anybody that wants support has to go to start their process at Virginia Williams, and then from Virginia Williams, then they're dispersed to the many different agencies. And so it's not a guarantee that somebody experiencing homelessness is definitely with Community of Hope for that support. But looking at ways to support anybody pregnant who's experiencing homelessness with care coordination, and also just support navigating the system to get them into a better space. Next slide. So right now, I am the director, I have an associate director, I have a birth center manager, I have a lead midwife, I have an admin practice manager. We have a lot of people because there's a lot of things to be done. I have 8.75 FTEs. We're probably the largest practice, one of the largest practices in DC. I have 4 per diem birth assistants who happen to be all RNs, but I also have a non-RN birth assisting JD, job description as well. We are a freestanding birth center, but we all have privileges at the hospital. And it looks like the midwives, because again, I also want to be conscious of now adding to any time I have the opportunity to talk to anybody, midwife burnout, provider burnout, trying to make sure that we're not only building practices that can be sustained, but that just don't eat, shrivel people up as they're trying to practice. And so full-time looks like a day and a half of clinic, 4 hours of admin, and 2 days of 12-hour call a week. And my midwives rotate through to also cover our home visits. Next slide. Challenges, turnover. We did not wake up and get here. It took lots of years and building and mistakes and failures and figuring things out to get here. And there are also a lot of people that gave a lot of passion and just a piece of their soul to grind and get us to where we are, and they burnt out. So turnover is real. We also still, probably are not the strongest, compensation salary across the country. Still, midwives caring for under-resourced families usually make less money. And that is something that also needs to be discussed. Covering call for 2 sites is hard. So at this moment, when you're on call, you're covering for the hospital, you're also covering for the birth center. And we bump. Of course, we'll have days of nothing, and then we'll have a baby at the hospital and a baby at the birth center, and like trying to figure out coverage for that. You have to have a strong partnership with the hospital. We are very fortunate. Not only do we have a strong relationship with the hospital and the docs, we also have an extraordinary relationship with our maternal fetal medicine, who we are able to call them on their cell phones, and also, have them give us support when we run into complications. Super hard to break even, because what did I tell you guys when I started? Birth doesn't make money. So really, really hard to still break even, really hard to negotiate with insurances. Our reimbursement could always be better, right? It could always be better. And matter of fact, I just heard about, I think it's Colorado, where they're looking at making sure that like the pay is the same for Medicaid and commercial. But yes, reimbursement is a huge, huge issue. And then really, really also learning how to bill and understand midwifery in an FQHC. And when it comes to birth, I think FQHCs have a lot of midwives, they have a lot of NPs, and they definitely align them together. And there are a lot of things that are similar, but there are a lot of things that are different. And so it's including the billing and figuring out those pieces. Took a lot of time to kind of work with billing. Next slide. Lessons learned. Gotta have buy-in. Gotta have leadership buy-in. I feel very lucky. My CEO, my VP of clinical services, both, like Christina had mentioned earlier, have experiences with their own, personal experiences with midwives and out of hospital birth. But like, you gotta have buy-in from the higher ups. If not, you won't be able to build. Time. Nothing happens immediately. Those centering groups I was just talking to you about, there was sometimes it was one person, then it was 2, then it was 4, then it was 8. It takes time to really, really build. The amount of patients we're taking care of, the amount of deliveries, nobody walks out the door with, having 8 FTEs and, serving 40 patients a month and, catching 35 babies. It takes time to build, and while you're asking for this buy-in, you need to make sure that you let them know they also have to be patient and know that things take time. Really, really had to learn how to adapt midwifery model and FQHC operations. One of the examples I used is the 20-minute visit, right? That's the standard for most FQHCs. And we're going to say no to that. We need more time. We definitely need more time. Midwives usually have longer appointments. So it was such an experience to, really, really navigate having longer appointment times for, especially for like new obstetrical appointments. Another example I'll give is, standard is 6 weeks for a postpartum visit. And no, midwives always see people before 6 weeks, really wanting to make sure that we were doing early postpartum care and how to support families. It has been such an incredible opportunity and experience. Um, if you would have told me I would still be here after 10 years, I would have said you're lying, but here I am and I don't want to go. And I'm still having a good time. So it definitely has been, had its moments. It's been hard, but it's been so, so worth it. And I feel very, very, just very lucky. I get to work for an organization that allows me to dream and to create what I feel like is going to be part of the solution to change outcomes for maternal mortality and morbidity, and unapologetically focused towards Black families. Next slide. That's it. That's all I got for you.
Thank you,
Thank you.
Ebony. Thank you, Christina and Indra. If you could turn your cameras on too. We are down to about 12 minutes. And the last minute I need to give to Michelle to close us out. But I would like a couple of questions, and thank you all, Indra and Chris, for answering questions in the chat as they were coming through. So that's wonderful. I'd like to ask you all about, because each one of you talked about the time and the effort it takes to really implement a community birth ecosystem. Could each one of you talk about, if you could prioritize one thing to get started, what that might be? I could ask each one of you to do that. Sorry, I cut you off guard.
I'm
I'll
happy
get
to jump in first.
you go, Chris.
And only because we haven't been able to do this yet, and I think it's such a critical piece, is the public information campaign. I think just, anytime you talk about having a baby at home or the midwifery model, or just how Ebony was just like, and we do all this and we all do all this, and everybody's like, what? I think that if we could start as early as possible, the children's books that I read to my kid, the things we talk about as children are growing up, so that our common understanding of having a family starts with this as knowledge. And then we don't also have to backtrack and be like, oh, and also people need choices. Oh, and also human rights. Oh, and also equity. If we could start with that, and that was our floor, I think we'd be a lot closer to normalizing and financially supporting what it means to change the ecosystem.
I love that.
That reminds me of taking a field trip when my kids were in elementary school. Parents got to help do field trips. So I took a group of elementary school kids to a birth center. And I loved getting to talk to them about who midwives are, and they got to actually meet with the home birth midwife as well. So to your point, Chris, I agree. Start early, talk about midwives, talk about birth to kids. Because it is something that people kind of find themselves right up against in the moment, as opposed to really getting to have a lifelong view. But I guess the thing I would add is to really think about how we make choices about what we value. To your point, Ebony, that birth doesn't make money. That's not a natural state of affairs. That's policy choices. It may be just as true that orthopedic surgery didn't make money, but we've made policy choices that make it possible to make money in that field. We could make different policy choices about what we value. And that's where I would start. Really think about, what do we value? What are we valuing with how we pay, with what is supported, with where there's infrastructure? I know that's kind of a big one, so slightly maybe cheating, but that's mine. Think about what we value.
Um, Mm, so many things. Um, where do you start? I know this is gonna sound lame, but like just start. Just try. Even small things, really, really can be so impactful. You know, I think one of the examples I can give is like I just started off not saying no to late patients, and so many times when I talked about that, um, people were like, "What?" And I was like, "Yeah, we don't say no to late patients. If she's 4 hours late, we still see her." But that kind of just started the chain of like, no, we're going to change how we're delivering care. We're going to change how we're engaging families. We're going to give back more of the power to these families. We're going to talk about what reproductive justice looks like and how we can shape how we're providing that care in that framework. So I would just say, even if you feel like it's small, just start, do something and keep going.
I have another question for you, Ebony. When you think about your birth center, and I know you use nurses, have you thought about CPMs? And what might adding CPMs to your workforce do in terms of expanding and broadening reach?
I would love to have CPMs. I'm stuck with licensure, state regulation. CPMs just got um, licensed in DC. I'm also stuck with who's my insurance carrier.
Mm.
So I think that, you know, still need to do some work, but I would love to have a CPM. So what do I do even though I can't like technically hire a CPM? I try to engage with the community as much as I can. Um, I had for a long time had a CPM student as a birth assistant. She was my fave, y'all. I ain't gonna lie. Um, miss having a CPM student as my birth assistant here in the birth center. Um, I support them utilizing our space for trainings, trying to have like meetups, because I hope we can get to a place where one day I can hire a CPM, but we're just not there yet.
And so maybe that sort of speaks to, so if I answered that question for myself in terms of priorities, I think even just understanding the difference in the types of midwives, certified professional midwives versus nurse midwives, what is the licensure in your state? What is the availability? And then really thinking about, what do moms need? I love, Christina, what you said about, just raising awareness about the options and the opportunities. I think, the work that needs to happen around financing, that is so important because we can't have folks open a bunch of birth centers and then they close. So we've got to fix this finance issue. Yeah, there's just so much more to do. Okay, so I'm going to say each one of you, the last few minutes, if you could one last statement for everyone, I'd appreciate that. And then we'll turn it over to Michelle to close us out.
Oh no, does this mean I have to go first for the last statement? Um, okay. I think my colleagues have covered so many things beautifully. I agree with what Andrea just said. Learn about the different types of midwives. It's also a policy choice that we have an alphabet soup here in the United States, but we do. Um, I really agree with what you said, Ebony. Start somewhere and keep going. And of course, the work Chris is doing and the fact that people with community birth experience are involved in the doing is so important. I answered JC Montoya Price's question in the chat about, how can people in early childhood be a good ally? And included a tool that we've created for answering just that question. But part of the answer is, listen to who's already out there doing the work. Even though it might not be immediately obvious, sometimes it's on purpose not obvious because there are hostile conditions. But I guarantee you there are people everywhere who know about community birth in your area. I would start to try to find them and listen to them.
I will just say, y'all, birth centers are not the only piece of the answer. I mean, it's going to take more than birth centers. The ecosystem, the policy changes, like it's going to take a lot of different things. And I just want us to name that and understand that more than birth centers.
Absolutely.
And I'm going to close just by sort of taking little bits of what everyone said and just, I think that our project for the next 10 years is really putting birthing parents, families, and children at the center of policymaking and of money. And really, you know, sort of as I think about the days that I have working in government, I'm either working with, there's no money for small children, there's no money for early education, there's no money for health consultations, and really sort of how can we, it is really hard for a legislator or somebody with power to say, I don't like birthing people, I don't like children, I don't like women's, I hate babies. That's a hard one for them to say in public. And so really just pushing on how are we going to move the needle to center families and small children so we can see those returns in the legislative budgets in the next decade?
Well, rock stars, you guys presented and did this at the Build conference, and now to have done it nationally. I love each and every one of you, and I thank you so much for sharing with us today. And I'm going to turn it over to Michelle to close us out. Thank you all.
Thank you, everyone. What an amazing, amazing presentation. I know that just from the responses in the chat and the questions that came in, you will be hearing from lots of people who want to learn more from you. So get ready. So here are our presenters' contact information. You will be getting the slides and you will be getting the recording. You'll also be getting their biographies and other information about them. So please don't worry. You can share the recording with your colleagues, and I'm sure they will be very glad to have an opportunity to see it. We would also very much appreciate you completing the survey that will pop up once you exit the webinar. Every little piece of feedback is very much paid attention to, and we appreciate you telling us what you liked about the presentation, what you think we could do to improve it, and what you would like to learn more about, because that helps guide our agenda and what we offer to you through Build and through the Prenatal to 3 Capacity Building Hub. One more plug for the XChange. If you are not a member of the XChange, please, I think do we have a slide? Yes, we have a slide. If you're not a member of the XChange, please join the XChange. It's a great way to continue the conversation. We welcome you. I think Zan at one point put the link in the slide, or you can use the QR code to get signed up. I want to thank everybody, the presenters who were amazing, all the people behind the scenes who were checking on questions that came in and doing the tech work for us. Thank you so much. Hope you have a great rest of the day, and please come back and see us next time we offer a webinar. Thanks.